Good morning. I thank you for your presence and for the attention you have kindly given to my research work. I have the honor to present our work to you, which covers triage and patient flow management in emergency department during the COVID-19, Sahloul and Hached hospitals. This work was developed by myself, Imen HAMZAOUI, and the following authors, Dr. Aida BOUZIR and Professor Saloua BENAMMOU. First, I present the plan of my work. My presentation is based on four essential points. I start by defining the work context while defining the issues. Then I fix the work methodologies. Then I present the experimental results accomplished in this work. Finally, I would eventually close with a conclusion and some future work. We start this work with an introduction. Health establishments seek to provide patients with the best possible service. They seek to improve the reception and care of patients is the ambition of all emergency departments and care facilities. With the COVID-19 epidemic, we have another problem risk of the risk is the risk of spread and propagation of the disease. So the growth in utilization of emergency care is being observed in the European Union countries. In the USA, emergency admissions expand about 50% from 1992 to 2006. Also in England, admissions to emergency department have a low growth of 9.3% from 2014 to 2017. So with the COVID-19 epidemic, we have another problem, the risk of spread and propagation of the diseases. So in the literature, we present this table that outlined diverse approaches. The diverse approaches to record, the analyze and improve the factors affecting patient flow. They are all recent works from the two last years. Now we pass to the second part of our presentation, methodology. Our methodology is based on two parts, patient flow management approach and the triage. In the first, we present the proposed approach that describes the path for a patient from his coming to the emergency department until his admission to the doctor. In the second part, the triage of patients will be according to this CTIS, the Canadian Triage Acuity Scale. Now we move to the third part of our work, experimental results. So in order to verify that our suggestions framework is implemented, we propose a set of information gathered from two hospitals, Sahloul Emergency Department and Hached Emergency Department. The two hospitals are located in Sousse in Tunisia. The patients were split into 5 types, A, B, C, and D. Before, the period of study was during the month of April 2021. The patients were controlled for 12 hours per day along this month. During the first 2 weeks, data was aggregated from 12 AM to 12 PM, and on the last 2 weeks from 12 PM to 12 AM. The sample size between 12,000 and 50,000 patients per month. It means between 400 and 500 patients per day. So the patients were split into 5 types: A, B, C, and D and E, as well as their maximum pending time. Based on the Canadian Triage Equity Scale, all categories are determined in terms of maximum waiting time for response to the number of patient days, and percentage are presented in Table 3. The proposed approaches of patient rank according to his or her medical condition. So as shown in Table 3, we give a comparison. We give the patient waiting time comparison before the application of the proposed approach. And in Table 4, we present the patient waiting time comparison after the application of the proposed approach in the 2 hospitals. Also, the figure illustrated this comparison and show the reduction of waiting time in the case of the 2 hospitals. So, as the interpretation, we look that the results show that the average waiting time of different patient types are decreased to achieve the standard waiting time. Then we can note that the categorizes A and B with the important reduction of the waiting time, we raise the success of this reduction on such crucial categorizes in which sometimes 1 minute sampling helps a life chance for them. In our proposed work, the main mission after the triage of patients to identify COVID-19 cases is presenting a better patient flow management by minimizing the max waiting time. So now we move to the conclusion and future work.